and welcome. It is my pleasure to introduce tonight's presenter to help us learn about this year's topic. Dr. John Molteni was recommended to us by our friends at the Hospital for Special Care. So I'd like to thank them for helping us to secure such a well-noted speaker. I know Wendy D'Angelo from the hospital is here tonight. And Wendy, on behalf of the Catalyst Fund, thank you to the hospital and its support for our program. Dr. Molteni is an associate professor of counseling and applied behavioral studies and director for the Institute for Autism and Behavioral Studies at the University of St. Joseph's. He has been involved in the education of individuals with autism spectrum disorder for over 20 years, all of which have involved the development of educational programming in public, non-public, private, and residential school settings. He is a board-certified behavior analyst and a licensed psychologist. In these roles, he has provided recommendations for school and community programming as part of the diagnostic evaluation and trained professionals to implement these programs. A number of years ago, Dr. John Molteni also did an in-service for the New Britain Public Schools, which was very well received. As a faculty member at the University of St. Joseph's, he has developed graduate programs in autism spectrum disorders within the special education department and applied behavioral analysis in the counseling and applied behavioral studies department over the last 10 years. These academic programs have trained almost 100 professionals, including teachers, behavior analysis, psychologists, to work more effectively with individuals with ASD across their lifespan. With the Hospital for Special Care, he collaborated to lead the development of the Autism Center that provides diagnostic and treatment centers for individuals with ASD and their families. Within the state of Connecticut, he has served on multiple statewide work groups focusing on early diagnosis and treatment, a review of the service gaps in the state, the Autism Feasibility Study, and is the governor's appointment to the Autism Spectrum Disorder Advisory Council. Tonight, Dr. Molteni will give us a broad overview of the topic, including current trends and services for children and young adults, age 21, statistics on the needs and gaps in Berlin, New Britain, Plainville, and Southington, and best practices in the way that a grant of $10,000 could make the most impact. Following the presentation, he will take questions. However, if you would like something clarified during his presentation, please raise your hand to ask. And now, please join me in welcoming Dr. John Molteni.
I think that's all the time we have, so feel free. It's totally worth it. The wait is totally worth it, I'm telling you. I do apologize. Completely my mistake, and then my GPS sent me to the wrong place. So user error all around, so I won't blame that. Okay, so we're going to talk a little bit about autism spectrum disorders, what they are, what it means, how it affects families, where are the trends and where are the opportunities. So I've tried to frame this more in terms of not so much identifying gaps, although there are many gaps in services, but saying where are those opportunities that there may be for this group to look at funding. So what is autism spectrum disorder? Very broadly, autism spectrum disorder is a neurodevelopmental disorder. I mean, it's developmental. There's a genetic component. There's likely an environmental component. It is not mercury related. It is not related to vaccines. So we are going to sort of get that. So if anybody has any questions about that, I've answered that question. Sorry. There are two diagnostic categories or criteria that we use to diagnose autism spectrum disorder, meaning there are deficits across two different areas. The first is communication and social interaction, and the second is restricted and repetitive patterns of behavior. So when we think about communication and social interaction, again, because we're talking about a spectrum, we may have individuals that are non-vocal, meaning they do not communicate vocally at all. They do communicate, they just don't do it through words. All the way up to individuals who are higher functioning, who have difficulties engaging in social conversation. So they may miss cues in conversation, they miss nonverbal cues, social nuance, etc. Okay, so we have a pretty broad spectrum in terms of how we look at communication and social interaction. And since all social interaction, all communication is social interaction, in all social interaction communication, they group them together. They used to be two different categories, but they're actually grouped together. This is a social interaction, albeit a very one-sided one, at least at this point. Right? I have to attend to the audience and make sure that you're paying attention to what I'm saying and laughing at my jokes. Otherwise, I need to adjust how I'm presenting. Currently, this is fortunate for us, we just had new updated numbers, which come out to be, from the Centers for Disease Control, 1 in 59. So 1 in 59. And this is taken from, by the way, 11 sites across the country that survey 8-year-olds. So every 2 years, they come out with a new number of 8-year-olds who are diagnosed with autism in these sort of regional areas that are being monitored. Okay? You should also know that there is a 6-year lag time on these numbers. So the numbers that we just got are from 2012. So in 2 years we'll get another set, which is from 2014. So there's a 6-year lag time, but we do get updated numbers every 2 years. So over the past couple of reports, there have been changes in the diagnostic criteria for autism, which I won't go into today. And so we have to think about those things as we go along, and we may continue to see increases. The only time we have not seen increases was the last one. This will be loud. Okay. Beware. You asked for it. All right. So last time it came out was 1 in 64, which was the same as the prior 2-year survey period, which was pretty good. So we were thinking, oh, maybe it's flattening out, and then this year we went down to 1 in 59. Yeah, now I'm too close to that. I have to go back over there to touch things. If I stand here. We can get a few more things to go wrong tonight. This is really. I'll get pulled over for speeding on the way home. We do also have discrepancies in terms of populations that are being diagnosed. So we tend to see greater diagnosis in individuals who are white, non-Hispanic, versus those who are Hispanic or black. And many diagnoses are occurring.
Perhaps the other room.
Yeah, I'll go. Diagnosis is also occurring after the age of. Can I turn this down? Yeah.
Don't stand in front of the speakers. The 2 speakers.
Where are the
stand
speakers?
behind them. They're okay.
Oh, good Lord. I'm going to stand like this. See if it doesn't work. Speakers, I can't stand near the microphone.
John, would you rather have this?
Yeah, let's do it with that.
Yeah. I'm so sorry.
No, that's okay.
Thank you.
Huh?
I love you. Okay, good.
Whenever you want. Okay, and then diagnosis is occurring at the age of 4. Now the problem with that is we have the ability to diagnose autism around the age of 2 fairly reliably and even younger. So we're getting better and better at identifying criteria related to autism with younger children. The problem is if we're not getting diagnosed until age 4, now individual children are already in preschool. So they don't get the advantages of early intervention, opportunities to develop some language skills prior to going to preschool. So this is a big problem. Again, we also have higher diagnosis in white populations. Does that mean that individuals of Black and Hispanic populations have less incidence of autism? Well, not necessarily. We don't know why that is. It may be due to many reasons, lack of access to care, and these types of things, which is something that we've experienced at the Autism Center at the Hospital for Special Care in doing diagnostic. I think our average age of diagnosis for many of the kids that I saw was around age 9, which is terrible. This is terrible. You can't have that. And one of the changing trends over the years has been that more and more individuals who do not have an intellectual disability receive a diagnosis of autism. So about 40, little less than 50%, about 44%, do not have an intellectual disability, which means that these individuals are participating in fairly typical classroom environments, typical community environments, which actually is a great area for struggle for many of them, particularly in the social realm and oftentimes in some things related to academic work, which again, I don't have time to go into today, but it's something you have to consider because these are individuals who often will end up going to college and can sort of handle the structure of post-secondary educational settings, but then won't be able to be employed because they lack some of the social skills and soft skills necessary to sit for an interview and get a job that way. In fact, I was just meeting with someone this year, who's a graduate from St. Joe's, graduated from our nutrition program, super student, 3.7 GPA, and she can't get a job, and she can't even get into the graduate program at St. Joe's in her area because she can't put together the application. She can't advocate as well for herself, even with the people who knew her. And so I've been working with her. She actually decided to disclose her autism in her most recent application, and it was actually one of the most wonderful essays that I've ever written. I've ever read. It was good. So when we think about, we have to think about the costs related to autism care. Now, care comes in a number of different areas. It includes special education. It's a fairly large percentage of special education budgets. Of education budgets include special education. There's medical care. There is lost parental productivity, so we have a lot of families that are not able to work full-time or even part-time because they have to care for their children, because their children often demonstrate behaviors that are difficult for a typical daycare setting to manage, or find a babysitter who can address the needs of someone with more significant cognitive needs, self-care needs, domestic needs, and those types of things. So finding care, accessing care is very challenging. So about 11.5 to 60.9 billion, that's a fairly broad perspective, but that's across different parts of the country. So some states may pay more, some states may not pay as much. So for Connecticut, just in terms of special education, these were some data that I was able to get. I'm still trying to get some data from Medicaid in terms of utilization within these 4 towns. I was not able to get that prior to, because they have to go through 20 layers of bureaucracy to actually get approval. And they're all people I know. Like, well, could you just say yes? I just want to know how many people utilize Medicaid. And Medicaid actually is a relatively new entry. Insurance coverage for autism services is a relatively new entry into the service provision for individuals with autism. Prior to 2008, there was no insurance coverage for autism services, specific autism services. Those typically involve things like applied behavior analysis, which is a set of procedures that are based in principles of behavior that are used to educate and address behavioral challenges in individuals with autism. And since 2008, that's been available. And it wasn't until about 2 years ago that Medicaid then was required to start paying for autism services. And at the hospital, that's primarily where we get our funding for services. One of our patients have Medicaid. So the overall prevalence in Connecticut is about 1.8%. Now that's fairly standard for the population numbers that we saw before. But you also have to realize that not all students with autism have special education services. It's not required. Some of them don't need them. They probably need some supports, but they don't necessarily need the level of support in a special education program. And autism comprises about 12% of the special education population. So of all the different diagnostic educational classifications they have in Connecticut, about 12% is in autism. And those trends have been rising fairly consistently, while other categories have not gone down. So some of the discussion is, well, are we just calling what we used to call an intellectual disability? Now we're just calling more people, diagnosing more kids with autism because they can access more services. Well, as an ethical practitioner, I would say I don't do that. That would be not a good thing to do. Is it possible? Sure. Is there some diagnostic substitution that might be going on? Sure. But the criteria for autism are pretty specific, and those diagnostic criteria are what we use to make those classifications. So the whys and wherefores of why the increases are being seen is something, again, I don't have time to talk about today, but there are many. Okay, so here are, within the state of Connecticut, these are the number of students in the 4 towns that we are surveying that receive special education services under the educational classification of autism. Okay? So, New Britain, obviously larger school districts have more numbers, 190, 39 in Berlin, 50 in Plainville, 109 in Southington. Now again, these are just the students who are receiving special education services. So there may be another whole group of students that are not receiving special education services, but could benefit from some community-based services perhaps.
Well, wouldn't those students generally be designated as 504?
Some might, if they have a medical diagnosis of autism,
Right.
if they're diagnosed at all.
Right.
Yeah.
Okay.
Good point. Autism prevalence rates are pretty consistent. Plainville must have some good schools because people are moving there. And then their percentage of special education. Okay? So, yes?
And so what year is this from and where?
This
how
is
did you
current
get
year,
this?
2017, last year, 2017 to 2018.
And the source?
The source is, oh, I don't have my computer with me. I will send that to you. It's publicly available, and you can search by town, by year, and you can look at trends over time as well. It might be. I'll get that to you. Okay. I also brought some data from Hospital Special Care. These are unique patients seen within the past year in our inpatient and outpatient programs at Hospital for Special Care. New Britain, obviously, again, the highest. Southington, Berlin, Plainville is not as well represented. Again, primarily our patient population tends to be Medicaid only. Not that we only take Medicaid, but we get a lot of individual Medicaid. So if we were looking at Hartford and Meriden and Norwich, you'd see a lot more patients from those towns than those in our area. So those are the kinds of again, these are individuals who actively seek out services. Those services can range from diagnostic evaluation, psychological evaluation, psychiatry, occupational therapy, speech therapy, family therapy, psychiatry, the various services that we offer at the hospital. Okay, so what's available? Well, special education is available. And of course, the unique thing about Connecticut is that almost every town has their own way of doing special education, unless you're in one of the regional school districts and you get some combinations going. So there's a lot of variability in terms of quality of special education services, what's available for individuals. There's out-of-district placements for students who cannot be served adequately within their public school settings. But more and more school systems are trying to develop programs that they can support students with autism more effectively within the public school setting, which I applaud. I think that's great. I work with a lot of public school districts to do that kind of work because that's important. What's available clinically? These are categories that are available through insurance right now: diagnostic assessments, speech therapy, occupational therapy, applied behavior analysis, individual and family psychotherapy, physical therapy, and social skills training. So these are just some categories of things that are available. Now, whether they're fully accessed, I'm not sure. I can tell you that every time we open a service at the hospital, it gets booked up and we end up with a waiting list immediately. We now have 2 full-time psychologists, another sort of per diem psychologist, and we still have a 6-month waiting list for psychological evaluations. Now, delays in evaluation are problematic because then those are delays to treatments. Yes?
I have a question about the diagnostic assessment.
Yeah.
Is it all observation?
No, they're standardized tests. So typically we'll do cognitive evaluations, some adaptive skills scales, and there are some standardized or semi-structured autism-specific evaluations that we use. So there are some observations, but they're structured in a way that we can pull for some of the skills that we're looking for, whether it's social communication or restricted repetitive patterns of behavior. Occasionally we will do a school observation as well. We do get school input as much as possible when we're making a diagnosis to see if everyone's seeing the same kid across all settings, because sometimes that doesn't happen. So that's what's available, so don't pay for that. You don't need that. What we're really facing now is sort of this wave of student population that's moving towards post-secondary transitions. As any transitions past the age of grade 12 or the age of 21, depending on how you're receiving those services. So we have a number of individuals, again, a lot of those who are cognitively do not have an intellectual disability, who are going through school and they're academically maybe on grade level. and they're not receiving vocational training or independent living skills. Transportation is a big issue, and community-based social opportunities or activities. So often we'll get really good engagement, perhaps during school or even some structured activities. As soon as they graduate, they're home, they're not working, they're not in college, and they're sitting in their basement playing video games. Okay. So they're not part of a group anymore. They sort of, what parents will say, they fall off the cliff, right? 21 comes and now there's nothing. Because you're not entitled to it anymore. There's no free and appropriate post-secondary education. You can get access to services if you qualify. If you don't have an intellectual disability, though, there is what we call an autism waiver in the state. It serves about 50 or so people with a several hundred person waiting list. So there are adults who are waiting to get services, and they just can't access them because they don't have they've been allocated a certain number of spots. And so someone either has to stop receiving services or stop receiving services for whatever reason for someone else to get in. So it's unlikely that those folks are going to get on anytime soon. A lot of parental supports. Most issues that we hear from parents are related to behavioral supports in the home. So children having behavioral meltdowns at home, or they have difficulty going shopping and getting chores done and doing things around the house, or doing things as a family, like going to a restaurant, going to a movie, and those types of things, because those are really challenging at times. There's a lot of, I didn't actually talk a lot about restricted and repetitive patterns of behavior, but as a diagnostic criteria, those things are fairly important, because what that looks like is often rigidity. I want things the same way all the time, this way, this is how it goes. Don't want my food to touch, I want my socks to be the same color at the same height at all times. If they fall, I have a temper tantrum. I don't like that. That's not good. I also like to have very specific topics of interest that I like to, and I know everything about it, and I like to talk about it. Mine happens to be autism. Really good at talking. It's a spectrum. We're all there somewhere. It's just a matter of other repetitive patterns of behavior could be things like body rocking, flapping your hands, making loud noises, and those types of things. So again, there's a pretty wide range of things that we see. But that rigidity piece, that need for sameness piece, is something that, again, is very problematic. Changes in schedule, set kids off, it's really problematic. So parents struggle with that a lot. They also have trouble teaching, effective skill teaching within the home. They have challenges in teaching their kid to go to the bathroom, to use the toilet, to dress themselves, to do chores around the house, to bathe themselves, hygiene, brushing their teeth, etc. Okay? And then a lot of the planning for future transitions, so financial housing, access, and services. So what do you do? There are now essentially 529 plans or college savings plans, but they're for adults who are not going to go to college. So they just passed a law prior to the end of the last administration that approved these essential 529 plans. So you can now put money in that's going to be used for care later on. Now, if you have the financial means to do that, that's wonderful. Again, what about those who do not have the financial means to do that? A lot of the members of our advisory council, those who are on the autism spectrum, talk about housing a lot. They need a little bit of support. They need a little bit. Someone just to check in once in a while. They don't need a lot. But they don't have, though. There aren't good housing opportunities in places where there's good transportation, because they're also not driving. So unless you're living in one of the larger city areas, having transportation is problematic. Again, unless you can access medical transportation, or you know how to call Uber. And you have the money for that. So, how can the money be used? Well, I'm a big fan of partnerships. If I'm going to make a recommendation to this group, I'm going to say find groups of people who want to work together on a project, not one group that wants to do it on their own. And the problem with doing it on your own is that it doesn't always generalize. So you have one pocket. What we have in Connecticut, this came out of a feasibility study we did way back in 2008. We have a lot of pockets of competence. Right? There are groups that are doing good things here, over there, and over there. Nobody in the eastern part of the state is doing anything, by the way. Very little over there. I live in the eastern part of the state. There's almost nothing over there. I don't know what happens. It's like you drop off once you cross over 91. No, everybody stops working. I don't want to do that. Too many trees or something. I'm not sure. But working with school and community partnerships to work on vocational training programs. Okay, so getting employers to actually open up to the idea of training individuals with autism to work. Now, sometimes the rigidity in the rule following is really beneficial, right? If you have repetitive tasks or things that need to be done over and over again. But I also don't want to limit people because, well, you have autism, so you do the data entry because you like to do repetitive things. Well, no, they have their own interests. They have things they want to do. So how can we get them into those things that they might have an interest in and might be willing to work on with a partner, right? Genuine and authentic vocational opportunities, not just sort of the things we have available, which often ends up being like stocking shelves or wiping tables or, it's like part jobs. Like you can't get a job just wiping tables. There's no job that just involves wiping tables, right? Doesn't exist. I've tried, I've looked for one, can't find it. I have to teach and do other stuff. Partnerships to support parental involvement in educational planning for post-secondary goals. So what this means, this is a very broad area, obviously, but we all want people to start thinking about transition planning earlier. As a parent, we think about transitions forever, right? We think about our kid when they're 21, 25, 30, 40, all that stuff. We worry about that from day one. And we want parents to be more involved in that educational planning in a very proactive way with the schools, right? Get the schools to start thinking about transitions early as well. I mean, they're required to do it at a certain age, 15, 16, it's usually a little late at that point. Again, you have to build those foundational skills early. So how can we get more parental involvement? So this is almost parent education around how to do good school, right? Collaborating with the school, not in the sense of advocacy and saying, know your rights, know me. That's fine. There are people who do that too, by the way, so we don't need to do that. What we need to do is help educate and help the teams work together really well. Partnerships to establish community-based activities to promote healthy living. Again, we've talked about, I want a kid who's going to want to go go for a walk once in a while. If they want to go to the gym, that's even better, right? But starting to instill some healthy habits, healthy eating habits, exercise programs, again, whether it's in school or in the community. Again, there are some adaptive programs that are out there. In Chapter 126 of Bristol, for Zoo Oak Hill, it's a more of an inclusive program. And again, that takes some work. It takes some, we have to educate the communities about how to adapt to individuals with autism. Now, of course, we also want individuals with autism to live in the communities that exist, right? Those aren't always conducive to serving individuals with disabilities in general, accessibility and otherwise. If you ever went to the University of St. Joseph, accessibility is a problem. We have a problem with accessibility. Very few entry ways for people with disabilities. But anyway, we're working on it. It's fine. But those are things, partnerships to establish parent training and behavioral interventions, teaching skills within the home. Again, working together to say, all right, here's what we can do. Here's how we can help you get into this better groove with your child. Right. Parents, I have 2 children who have IEPs. They don't have autism, but they have needs. I have 3 children. 2 of them have special needs. The other one's just a teenager. And but, so I get to go to PPTs all the time for my kids, which must be delightful. They love to see me coming. Let's talk. Right? So I do this for a living, and this is hard for me, with my own children. Right? And I'm a professional. But when it's your own child, it's something else. It's something different. There's a guilt factor to that as a parent in some cases. And so sometimes it's hard to tell, we want parents to keep those expectations high. Aim high, right? Keep them high, keep them up. You want your kid to do this. All right, let's get the kid to do this, right? You want that child to be part of your family. Let's work towards that. All right? And that's hard. Sometimes that's hard work. But again, the earlier we do it, the better off we're going to be. And if we're not diagnosing kids till they're 4 or later, we already have these patterns of behavior that are developing. I tend to work with kids who are 15, 16, 17 years old. Now, if you think it's hard to change a 4-year-old's behavior, try changing a 16-year-old's behavior. Better yet, try changing a 40-year-old's behavior. Because most of the work that I do is changing adults' behavior towards the kids that they're working with. And you have to implement this plan that I wrote because this is going to work for this kid. That's hard. Right? So those are just some of the opportunities that I think are available. There are many more, but again, I would really hope you focus on some partnership stuff, because those are the kinds of things that those are not available clinically. These aren't clinical services. These are services that are community-based and are going to really benefit, I think, the larger communities that you're working with now. So that's all the time I have. Anybody have any questions? Yes, please.
Here, I'm gonna bring I'm sorry, stand up. You can answer from here, and I'm gonna give people a microphone so that everybody can hear.
I don't think I need it with my voice, but I'll take
You
it
never
anyway.
know.
They insist. I tried.
I'm actually a first-timer in Catalyst, and I've actually had experience. My son is very high-performing Asperger's syndrome, and I'm wondering, my question is, educating the educators.
Yes.
Have you seen a trend that way as teachers come through the school system, whether it's St. Joseph, CCSU, because I think that's an important piece of the teachers, because they see them more than anybody except for the parents.
Yeah.
I know my son in particular was in kindergarten, and his teacher put him on a behavior chart.
Yeah.
Nothing worse for a child on the autism spectrum than put them on a behavior chart, at least best as I can tell. And wondering if you've seen that kind of trend, because I know that's a huge piece of it, because early on, kids either really like school or really hate school, and it's tough to be able to turn them. And just wondered if you've seen that kind of trend in a positive way with educators.
I think there's certainly, of all the schools that I worked actually quite a bit this year with my own home school district. I actually filled in for a couple of months as a behavior analyst, which is just wonderful. They hired me. After 13 years of being in the district, they finally said, sure, come on, do something. Yes and no. I would say in sort of the regular education training area, there's very little in special education in general, much less autism. What we do have in the sort of master's level and beyond, where if you want to get a permanent license, you have to do that. We do have a lot of people who come back and do our autism certificate as part of a master's for some other stuff. What I do find in the sort of professional development realm is that teachers are very interested in doing right by their kids in general. So they're very receptive to learning new things. But it's primarily the special educators that get it. And then again, if you don't have a kid in special education, then how does that work sort of universally with the regular education teachers? I don't want to defend the behavior chart to a certain degree, because I think general behavior management strategies are very effective if they're done well. I think the way most of the time they're implemented are poor, because they usually identify things that we don't want to happen. So you get like stickers and stuff for not having a behavior problem, which means you'd all get a sticker because none of you had a behavior problem, which was great. But did you do anything? Did you learn anything? No, I just sat here and didn't get in trouble, which is problematic. So some of that is getting better instruction so that you can engage kids more, so that often trumps behavior management types of strategies. That's what I do for a living. But so yes, I think districts are getting better too in terms of professional development around that. I know I did, and again, it's the professional development structure in schools is not great because it's sort of a one-shot deal. I did one for New Britain. It was one wonderful 3-hour morning, probably 2 years ago, and it never happened again. So it's kind of one of those things, people get inspired and like, yeah, let's do this, and then there's no follow-up, and it's kind of like, okay, well, I remember back when Dr. Mulfenny came and spoke to us. It was fun. And I did it in Tolland as well, where it's where I live, and I talked to all the teachers prior to the start of not this school year, but the prior school year. Again, everyone, we had a good time for a couple hours, and then, what happened just kind of drops off. So there needs to be this ongoing process that has not yet taken off. So it's progressing. It's just not 100% there.
Thank you.
Yes.
Do you think I really need it?
No.
You need it. Take the microphone.
She really doesn't. She doesn't.
I know. step away from the speakers.
I'm just concerned for New Britain where you had the 190 count age range.
That's K through 12. That's the entire district. So I don't have a breakdown by grade or anything like that at this point. But right now, what I do know, I just spoke to the autism director for New Britain today, and they have this group of children, again, this sort of critical mass of children that are moving through the middle school right now, and they're going to be entering high school soon. So they started a really solid program in their early intervention, their preschool program, and now those kids have moved up. And this is how it always starts, right? It always starts with you start with the little kids always, and then we sort of get this big group of kids that keep moving up and forced to change for the rest of the school district. So
Okay, because I was just thinking in terms of partnerships, right? Because I hear you.
yes,
And that's why I was looking at the age range, but I'm also concerned about, my other question would be, is there anything now for those youth who are moving through, especially the middle school, preparing them from the, the skills that they need to be successful at home and in the world of work?
right.
Is there anything that you know about?
Not in middle school, no.
Okay.
Again, that transition piece is required around age 15. So it tends to happen until high school. But again, these are conversations we've been having recently, is how do we do that better so that we can develop some sort of progression through middle and high school so the kids are ready. But it's a great question. It needs to start earlier.
And then Linda.
Have you seen something more where people are trying to educate parents that are undereducated to learn things to see if their children need to be diagnosed? Because we work with a lot of populations where you said it's not even represented. Minorities are not bringing their children because they don't want to deal with that, but there's so many kids who are on the spectrum that are diagnosed so much later, so we're missing that early on.
Well, what's supposed to happen is pediatricians, this is a recommendation from the American Pediatrics Association, they're supposed to be screening kids at 18 months at this point. Universal screening at 18 months. I think Connecticut's around 60%. The last time someone actually did some survey of that. About 60% of the pediatricians are surveying all kids at 18 months, so we're not quite there yet. The community health centers, we get a lot of our referrals from them. Again, a lot of times those parents are coming, though they're not quite sure why they're there, because we'll ask them, what brings you here today? I don't know, someone said autism. Someone said something about autism, right? So then we do that part. We try to educate as to what we're going to be doing and why it's important and what this means afterwards. But it's challenging because then we do want to have a care coordinator to sort of help with that, but then that's sort of accessible if you want it. You sort of have to push for it. So getting parents to advocate for themselves and sort of push for the things that they need, it happens. It often happens as those kids get a little bit more difficult to manage at home or in school, so it's not until they get a little bit bigger. Because when they're small, we can kind of move them around where we need them to be, and then when we can't move them anymore, or they start to realize that dead weight is a really effective way of not moving, then you have some challenges around that.
Okay, you gotta turn that on. And we're gonna have one more question
Okay.
after Linda.
Just talk into the microphone.
I like what you had to say about helping parents to understand how to intervene and teaching them how to teach their children what to do around the house.
Yeah.
One of the things we've learned at Catalyst is how to consider different types of proposals. And let's imagine that we send out our request for proposals, we get 3 different groups that come in and say, we're in doing this.
Yep.
Are there evidence-based strategies that we can follow?
Yes.
Is there a certification we should look for? How do we judge or compare what kinds of things should we be looking for to know that these things that are being taught are going to be effective?
Yes. There are evidence-based practices for autism. There are a couple of places that have sort of resources around that. One is the National Professional Development Center for Autism Spectrum Disorders, which is through the University of North Carolina. They also have a series of modules that parents can or anybody can access, really, that sort of has a review of evidence-based practice. Vanderbilt University has a similar program. And then the National Autism Center has a standards project that they do every couple of years where they update their evidence-based practices for autism. And the nice thing about both of those, the new North Carolina and the National Autism Center, is they'll tell you what ages these things work for, what skills they're used to teach, and those types of things. It's not, it's not just, well, we're doing this and this is good for everything. Sometimes it's not good for everything. It's good because the literature is pretty scant. It's really heavy. You got a lot of research done with little kids, and once you get into the middle high school, those kids towards 21 and adults, forget it. There's almost nothing. So the literature becomes very scant as to what's effective with teenagers and those types of things. As far as credentials go, you want to look for, as much as possible for a board-certified behavior analyst if they're doing behavior analytic work, because now there's a license in Connecticut, so there's a scope of practice. Psychologists also have it in their scope of practice because they have everything in their scope of practice, because they're a very powerful lobbying group, so we can do anything, which is great. Yeah, so anything that is that sounds kind of, if it sounds really good, sounds fun, it's probably not going to work. Right? Fun stuff doesn't work. Fun stuff can work. You can make things fun. If it involves crystals or anything like that, then no. Direct skill teaching is what you're looking for. You can certainly look at specific strategies they may use for that. But it needs to be of sufficient intensity, meaning quality time spent instruction. So it doesn't mean the more you do it, the better, because if it's a lot of garbage, then you're going to get a lot of garbage. But if it's really good and focused and targeted kinds of things, then you probably will get some good stuff. Thank you. You're welcome. Any other questions? Yes?
You didn't mention anything about medication. Is there a factor of medication in this?
There is only one medication that is FDA approved for use to address symptoms of autism spectrum, not symptoms, behaviors related to autism spectrum. There's no medication currently to address symptoms of autism spectrum, meaning the communication and social interaction problem and restricted and repetitive patterns of behavior. So it's only for behaviors, medication to address aggressive and disruptive behaviors. That's the only one that's approved at this point. Medications are used, they're used pretty typically, but most of them are off-label, they're not really used, so you may get a child who is getting a stimulant medication for ADHD-type symptoms. There's a lot of comorbidity of diagnosis, so you'll get a lot of mental health diagnoses, especially as kids get older, once they get into be teenagers. Again, our cognitively capable folk, our higher functioning folk, are very aware. They are socially motivated, but socially awkward, and so that often leads to a lot of emotional challenges because of rejection and anxiety around social interaction, because I'm not very good at it, so now I've been rejected before, so you get this sort of push-pull thing. So you may see some, this is why you see kids entering counseling when they get into high school. It's a big need actually in the schools, more in the schools, probably because social skills is a thing, but we don't teach social skills particularly well. I'm not good at teaching social skills, because when we teach social skills, we teach them like little adults. Have you ever seen 6-year-olds interact with one another? They don't walk up to each other and say, "Hi, how are you?" I've never seen that happen. They just they start doing stuff and they play, right? But we don't teach kids like that. So we need to get better at teaching sort of in the environments where our students live.
Thank you very much to our speakers tonight. I think we're definitely more educated about the subject. I hope all of our new visitors, all of our new members get a sense now of how we try to bring the experts to you and try to bring that expertise to you so that you will feel more prepared as we go into the discussions that we'll be going into in the next 2 meetings. So, in wrapping this up, it's now time for our raffle. Yes, it's gimmick time. That's right, folks. But, before we do that, we want to make one final check of anyone in the room who may not have made their 2018 commitment, or maybe haven't renewed yet, or is checking us out. Maybe you like what you see, maybe you don't. But now would be the time that we can add your name to the drawing. So we have entered the names in our magic jar over there that Kim is holding. We have entered the names of anyone who has paid for his or her or their membership before or at tonight's meeting. Yes, that does include all the new members who have signed up, as well as anyone who has referred anyone new to Catalyst. Yes, that's a little twisted. If you refer somebody, you're in there too. So if you're a member and you referred somebody, you're in there multiple times. So, that's our thank you to you. So no pressure if anyone here has decided to join. I wanted to make sure your name is entered. Staff are standing by and are ready to write your name down on a slip and take your gift information before you leave. I'm reading this because I want to make sure I get it right.
Tell us what we can win, Dave.
We're almost there. And while staff look for any raised hands in the room that are interested in finalizing things, let me review what we have to raffle tonight. We have two $25 gift cards to Angelo's Market in New Britain. Yeah, it's very popular. Yeah. We know what to give out. We have a Sony Blu-ray DVD disc player.
And it's new.
Hey, that's a little side joke. Anyway, we have a $25 gift card to the Good Cause Gifts in Berlin. And we have a one-year family membership to the Britain Museum of American Art. Any last hands? Any last hands? We'll take the money later. You can just raise your hand now. All right, just checking. I'll give you one last chance. Okay, so here we go. We're going to open up the raffle. You guys can do it over there. I'll grab the prizes which are under the podium, as I've been told. I'm trying to follow instructions. Aha! Okay, so we will do a gift card to Angelo's Market first.
Sharon Beretta.
Sharon Beretta! Our second gift card to Angelo's.
Betty Fumiati, she's not here.
Betty Fumiati. We will get that to Betty.
She's recovering from cataract surgery, so she could use the takeout.
Our gift card to Good Cause Gifts.
Also here in New Britain.
Rod and Sarah Brown.
Rod and Sarah Brown.
Rod and Sarah Brown. We thank them for their support. The Sony Blu-ray disc player, new.
Steve and Barbara Nims.
Steve and Barbara Nims. And I believe that's in here. This is it? This is it? Okay. I get signals from everyone. The museum membership.
Oh. Tom Satalino.
We hope you enjoyed that. We did, putting it together. But we're going to close now, and we just want to let you know there's still time to bring your friends to the next meeting. Still time to sign up more people. We blew the doors off our tote board. This morning we walked in the office and the tote board said, what, 55 members? 55. Then we had 59 by 10 a.m. And then now we're at 61. So we have 35 volunteers. Fantastic groundswell of support. We really appreciate that. Please make note of the future meeting dates. Thursday, September 20th, will be at Stanley Black & Decker University. That's once again will be 5:30 to 7:30. That will be sponsored by Stanley Black & Decker. And they are wonderful hosts, as the hospital has been. And the third meeting will be Thursday, November 8th at Shuttle Meadow Country Club. And our time at Shuttle Meadow is due to the generosity of an anonymous Catalyst member who sponsors that particular time that we're together. If you know somebody, please tell them about Catalyst. I think we have brochures up front if you need to take any with you. They're on the tables, okay. In the meantime, also if you have any interest in joining our steering committee and being part of that effort, please let any of our staff members know. And I have a few little notes here. If you didn't get your parking sticker for your validations, please make sure you do on your way out. We have them at the front check-in table to make sure you get that. Please drop off your name tags as you leave, as we recycle them and reuse them for each of our meetings. Staff, am I forgetting anything else?
No, you're good.
We're good? Thank you, everybody, for coming. Drive safely. We'll see you next time.